a seasoned expert and guest speaker today, Dr. Ayeni Mofoluwake. She graduated from the College of Health Sciences of Obafemi Awolowo University, Ile-Ife, about 22 years ago. She's worked in different governments and Nigerian Army hospitals before proceeding for a residency. She completed a residency about 10 years ago as a fellow, West African College of Surgeons, and associate fellow, National Postgraduate Medical College of Nigeria. Dr. Ayeni has a diploma in fetal maternal medicine from the University of Schleswig-Holstein-Kiel, Germany. And in addition, she has a diploma from Fetal Medicine Foundation, United Kingdom. She is a trained representative, endocrinologist, and minimal access surgeon, and currently works as the head of obstetrics and gynecology, Lagoon Hospitals, as well as the clinical lead, Lagoon Hospitals, Ikeja. We're absolutely delighted and pleased that Dr. Ayeni joined us today. I would like to encourage you to please celebrate her in the chat box. Hand of applause before she comes on. If you don't clap well enough, Dr. Ayeni will only present half of our slides today. So please make sure that you are celebrating her. Thank you, Dr. Ayeni, for joining us today. Next slide, please. Thank you so much, Barbara. Please, I'd like to see our hands in the awesome. Thank you very much. Awesome. Dr. Ayeni, over to you. We're ready for your presentation.
All right. Good afternoon, everyone.
Good afternoon.
I am Dr. Ayeni, as introduced. So we're having a discussion on HIV, human immunodeficiency virus. We'll be talking about the overview and prevention of the mother-to-child transmission of HIV. Globally, HIV was first, next slide please, was first reported in the world in 1981. In 1984, it became a global burden. But in Nigeria, we had our first case of HIV in 1986. So I'll be presenting this topic under this outline, the introduction. We're talking about what HIV is, the modes of transmission. Then we're talking about the mother-to-child transmission, the stages, HIV in pregnancy, how you do it, diagnose it. Next slide, please. Next slide, please. And the mother-to-child transmission generally. Next slide, please. So I've said before, HIV was first reported in Nigeria in 1986. Although some documents shows that in 1959, they found HIV in the blood sample of a man in Kinshasa, Congo. But that's as far back as now. But in Nigeria, our first case was 1986. That time it was found in very few individuals. Whereas in 1981 was 1.8%. 5.8% in 2001. And that's when we knew that we had a pandemic. And all sorts of efforts were made to reduce it. So in 2005, it became 4.4%. And as of 2014, it was 3%. Currently, in Nigeria, we have the fourth global burden of HIV, with 1.9 million people living with HIV. And about 1.4% of these individuals are aged 15 to 64 years. In fact, about 1.3% of these people 15 to 64 years are women. It's 0.2% are the ones that are children. Next slide, please. So, they found that the prevalence of HIV is in the southern part of the country, and Akwa Ibom State has the highest prevalence, 5.8%. That one in 2001. That's where they stay are. And the lowest in the northwest in Katsina State, which is a Sharia state, and they have 0.3%. Lagos State, where we are, is 1.4%. The complex route of transmission is sexual exposure. But second to this route of transmission is mother-to-child transmission, where the child acquires it from the mother. More than 90% of children that are less than 15 years that have HIV acquire it from their mothers. And this occurs about 25 to 40% of all HIV pregnant women. 5 to 10% of acquire in pregnancy, about 50% of them acquire during delivery labor, and about 5 to 50% of them acquire it during breastfeeding. Next slide, please. So let's talk about HIV, human immunodeficiency virus. You know, virus, they are organisms that cannot exist on their own. They need a host body to stay, and from there they replicate. But you see, the peculiarity of this HIV is that it enters the host body and takes over the immune system of the body. Imagine somebody taking over all the military and the paramilitary parastatals of a country. That means that country is vulnerable to external invasion. That's exactly what HIV does. And when left untreated, there is acquired deficiency syndrome, which you have multi-organ involvement and multi-organ failure. With uncommon cancers, which can even take the life of the patient and disruption of almost all the organs of the body. It was believed that HIV is not curable.
Okay, I think we might still be having some of that technical network challenges that she's having. No problems. What we can do is have Dr. Charity take over while we try to see what support we can provide Dr. Ayeni. Dr. Charity, are you available? Are you currently on ground so that we can? Thank you for standing by. Please let's enable Dr. Charity take over while we resolve the network challenges that Dr. Ayeni is having. Thank you very much. Hi, Dr. Charity, welcome on board. Thank you.
Thank you. Hi, everyone. Good afternoon. So my name is Charity McCoy. As Elizabeth said, I'm a clinician. I will go through the slides until Dr. Ayeni can join us. So mother-to-child transmission. So these are all the various ways that HIV can be transmitted from a mother to a child during antepartum hemorrhage. So things like when we have cases of placenta previa, or things like abruptio placenta. Those are some of the examples included under antepartum hemorrhages, and those are some of the ways that HIV can be transmitted from a mother to a child. External cephalic version as well. So for instance, in scenarios where we might need to manually turn the baby, where it's getting closer to term and maybe the baby is in like breech position and we need to turn the baby. So that could also be a cause. Another one is early rupture of membranes. So usually during the process of labor, the membranes will rupture on its own naturally. However, if for any reason this intervention needs to happen and it's happening at least, if it's happening before 4 hours of delivery, that could also be one of the areas where it could occur. Prolonged labor, chorioamnionitis, invasive delivery procedures, so deliveries where we're using forceps or where the mother is getting an episiotomy. Oh, please, can you go back? Thank you. Deliveries where we're using forceps to help the mother deliver, or deliveries where the mother has to get an episiotomy. Those are also avenues that could increase the risk of transmission. Preterm births, and then we see first infants in multiple births. Next slide, please. Okay, so breastfeeding, extended duration of breastfeeding. WHO recommends exclusive breastfeeding for the first 6 months and actually recommends breastfeeding up until 2 years, so extended beyond that. Early mixed feeding, breast abscess, nipple fissures, mastitis, and if there's any instance of oral disease in the infant. All of these are avenues where there could be an increased risk of transmission of HIV from the mother to the child. Next slide, please. All right, so the stages of HIV. Okay, so primary is characterized by flu-like symptoms, and this occurs in about 50% of people. In the asymptomatic phase, may last from 2 to 10 years. It's usually shorter in children, and what usually you will notice is that there's a steady decline in the immunity of the child. And then in the symptomatic phase, what you usually have is there's usually like a recurrence of infections, and the infections are usually like rare organisms that you wouldn't typically come across with in your like day-to-day practice in the hospital. And then also AIDS sets in at this point. Next slide, please. All right, HIV in pregnancy. So pregnancy is an immunosuppressive condition. Pregnancy may not worsen HIV infection or progression to death, but it may increase the infective complications in pregnancy like pneumonia, urinary tract infections, miscarriages, fetal death as well. These complications are seen more in women who are in the symptomatic stage of, like we just talked about the 3 stages of HIV. And so some of these complications are seen more in women who are in the symptomatic stage. And then the steps to prevent transmission of HIV from the mother to child is called MTC, mother to child transmission. Next slide, please. So how are the ways that we diagnose it? First of all, take a very good history, a detailed history from the mother, and then also by doing investigations, right? So, some of the tests are considered routine for antenatal tests. Essential components in testing for HIV in pregnancy include the pre-test information, then HIV testing with the same day results, post-test counseling, and follow-up counseling as well. Next slide, please.
Okay. Dr. Charity, just a quick one. Our speaker just informed us that she's back and able to continue. So I guess if that's okay, if we can please enable her to take over. We apologize for the glitches and the change in button, but thank you so much for standing by, Dr. Charity. Dr. Ayeni, if you can hear us, please let us know, and we can take over from here. Just confirming that Dr. Ayeni can hear us now. Apologize.
Rupture of membranes for more than 4 hours is a risk factor for the child acquiring HIV from the mother. And that's put into consideration, especially when we are doing induction of labor. Remember that in induction of labor, you need to rupture the membranes for the woman to actually deliver. So we need to consider the options well before going for induction of labor. Then choramnitis, labor lasting, spontaneous labor lasting more than 12 hours, induction of labor lasting more than 16 hours, they are all risk factors for transmission. And invasive procedures, vacuum delivery, the first baby in multiple pregnancy, twin delivery, triplet, the first baby is at more at risk. The same class we'll be discussing about it. Breastfeeding, when you breastfeed the child, when there's mixed feeding, or you breastfeed more than 12 months, that is when there can be risk of mother-to-child transmission of HIV. And when you practice mixed feeding, when you can you go back the slide so that they can follow? And when you practice mixed feeding, when the baby food mixed with breast milk, because baby food can cause inflammation in the intestines of the baby. And that's the reason why they can be increased. And when there's mastitis or oral disease of the baby. So we talk about the stages of HIV. The stages in the first stage may be asymptomatic, but about 50% of cases of a patient, they can tell you that they have something like catarrh. They have something like flu, they're just a little bit sick, but it's actually HIV. And then they go to nurse may last for about 4 weeks, 4 to 6 weeks, before they now go to the asymptomatic stage, which is characterized by decline in immunity. And it may last up to 2 to 10 years, depending on how strong the immunity of the individual is. That is why it is shorter in children, because children have less immunity than adults. Then you now have the symptomatic stage, which is characterized by infection by rare organisms. Then you are having candidiasis in the brain, you are having sarcoidosis, and also characterized by AIDS, which is multi-organ failure, a lot of them. So we have HIV in pregnancy. Pregnancy itself is an immunosuppressive condition. And that is why people who have autoimmune disorders, they tend to have current pregnancy loss, because the immunity of the woman has to be back for the pregnancy to thrive. Pregnancy may not necessarily worsen HIV infection or progress to death, except in symptomatic patients, but can lead to increase in complications of pregnancies, like pneumonia, urinary tract infection, miscarriages. I did a study about 5 years ago, which confirmed that this is true. These complications are more in women in symptomatic stage, and that is why there's a need to reduce or stop completely transmission of HIV from the mother to her child. So what is, how do you diagnose HIV in pregnancy? From history, the woman will come into you, I have HIV. she already knows that she has HIV. From testing, which is part of our routine antenatal test that we offer women, don't forget that these women does not need to do this test compulsorily. It's optional. So we should not enforce it on them. And before we do this test, we need to give them test information, let them why it's important to do it. And when they agree and give their consent, we should do the testing that same day and get so that same day so that we don't lose them. And we do post-test counseling, either negative or positive, and we do follow-up counseling. Why? Because the people that we test in pregnancy that are negative, we know we must repeat it in 6 weeks after delivery and also 6 months after delivery. Next slide. So we have diagnosis in labor. A woman comes in labor, she has no history before, but she gives you a history that she's positive. Or we have to discuss, if she has no history, if she has not done the HIV test before, especially those men coming from the villages, we have to discuss the benefits of HIV testing in them and the importance of having antiretroviral therapy in labor to reduce this risk to the babies. And we explain the HIV testing that is just a simple test, you just take blood sample, and if they agree, we offer them the test. Then the third scenario is a woman that you are seeing in the puerperium after delivery, but within 6 weeks. Those ones that were never tested before, or those ones who tested negative when they are pregnant, they should be tested 6 weeks after and 6 months after delivery. So what is PMTCT? These are packages that we offer women who are pregnant and their families and communities during pregnancy, labor, and puerperium. And the aim is to reduce and prevent or eliminate completely the transmission of HIV from infected mothers to their babies, that we also call the vertical transmission. So PMTCT is in 4 pillars. How do we intend to achieve this? We call it 4 pillars of PMCT. The first pillar is to prevent HIV infection in women who are of childbearing potential. So if they're pregnant at all, they are negative. So we don't even talk about PMTCT in labor and delivery or in pregnancy. The second one is preventing unintended pregnancies among women who are living with HIV. Why? Because we discovered that when they enter pregnancy prepared and very low viral load, they have no tuberculosis, they don't have AIDS, then the outcome is better. But if they have these conditions, it's better they are well treated before they become pregnant. Then the third pillar is preventing HIV transmission from a woman who has HIV and is pregnant to her infant, which is the real PMTCT. And the fourth pillar is providing appropriate treatment, care, and support to all women who have HIV and their children and their partners and their families. This involves giving them the same care you are giving everybody, avoid stigmatization, avoid any isolation in these women. Next slide, please. So let's look at pillar 1. In pillar 1, what do we want to achieve? Next slide, please. We want to prevent HIV infection in women of reproductive age. And for the ones that are married in their partners, how do we intend to achieve that? We advocate ABC of prevention. A, abstain from sexual intercourse for the unmarried ones. You can't abstain from sex when you are married, if not, don't want to break a home. Be faithful to a mutually faithful partner. The two partners should be mutually faithful to each other. The third one is the use of condom correctly and consistently. What do I mean? Some people use condom and it slips off. Some people use condom and it gets torn. Some people, they have the sex. It's when they want to ejaculate that they now put condom. That's not the correct use. Then we talk about safe and responsible sexual practices, which includes delaying the onset of sexual activity until marriage, if it's possible. So we want women to delay the sexual activity until marriage. Other things that we also do for the pillar 1 is that we want women to reduce the number of sexual partners, because the more sexual partners the woman has, the more she can have virus. I've talked about the correct use of condom, and diagnosis and treatment of sexually transmitted infection. Why? Because sexually transmitted infection can increase the risk of having HIV in the general population by 40%. So if it is not treated, then the risk of having HIV is high because of the inflammatory changes that happen around the vagina during with sexually transmitted infection that can aid the HIV virus in invading the system. Then we offer mother to child transmission, prevention of mother to child transmission of HIV to mothers, and HIV testing to pregnant women who are attending antenatal clinics so that they can know their HIV status. Because if they don't know, there's no way they know that they need to prevent it from their child. So we need to offer the HIV testing to them and also to offer them the prevention. Then we need to provide counseling for women who are HIV negative. And what are we counseling them about? We are counseling them that they are negative for now, but they need to continue to protect themselves, not to have the virus. And we need to teach them how to be able to prevent themselves. And we need to motivate them to adopt safer sex, family planning practices, and encourage their partners to go for testing. So we know if they are not serodiscordant or they have both positive or negative, so they can sustain this lifestyle. Next slide, please. So pillar 2. In pillar 2, we want to prevent unintended pregnancies among HIV positive women. And because unintended pregnancy in women who have HIV is about 51 to 90%, and this can lead to, this has been found to contribute 27% to maternal mortality. Why? Because they enter pregnancy unprepared with very low, very high viral loads. Some of them are not even on drugs. Some of them have tuberculosis. Some of them have opportunistic infections that can worsen the outcome of this pregnancy. So the reason why we are doing that is to ensure that HIV positive women and their partners, they have informed consent and they have informed choices of actions that they can take to protect themselves and plan for their pregnancies before they even go to it. So what do? We provide a good quality, user-friendly and accessible form of family planning. So for these women, depending on the other medical conditions that they have, we provide condom use. There's condom. Male condom, female condom. Why? Because we don't want reinfection. We don't want viral infection from other strains that can lead to treatment failure or drug resistance in these patients. Then we want to integrate these messages into our family planning counseling services consistently during antenatal care for these patients. And we also offer women emergency contraception. When they are not planning to get pregnant, no emergency contraception is a contraception you give after sexual intercourse, but with the aim of preventing pregnancy in a woman that is not protected. We should know that lactational immunity does not guarantee adequate contraception in these women. And so, even though they practice exclusive breastfeeding, and it must not be practiced in patients who are HIV positive. So let's go to pillar 3. In pillar 3, we want to prevent transmission of HIV to women who are positive, to what the infants of women who are positive for HIV. How do we do this? We do HIV testing, know the status of the woman, then we counsel the woman on infant feeding options so that when she delivers her baby, she'll be able to know what to do to reduce this, because we know breast milk is a form of carrier. Then we modify our obstetric practices. It's not everything that we do that we normally do for the ones that are not positive, that we do for the positive ones to reduce this risk. And we ensure that they are home antiretroviral therapy treatment, irrespective of the WHO clinical stage or the CD4 count stage. And we make sure that we give all infants of HIV positive women prophylaxis when they are delivered up to 6 weeks of 12 weeks after they have stopped breastfeeding, or in women who continues to breastfeed. So let's go to pillar 4. Pillar 4 is to provide appropriate treatment and to support HIV positive mothers and their families. what do we do? We give artificial reproductive, we make sure that we give antiretroviral drugs for all HIV mothers. Can you hear me now?
Yes, we've been hearing you, Dr. Ayeni. Please go ahead.
Okay, because somebody said she cannot hear. So I will also give cotrimazole prophylaxis. What is cotrimazole prophylaxis for? It's to prevent opportunistic infections like tuberculosis and the uncommon diseases that comes to women. We also want to do tuberculosis screening. Thank you. Tuberculosis screening in these women and prophylaxis and treatment in women who don't have it. We want to also continue the infant feeding options, counseling, and supporting these women in their choices of the infant feeding counseling. Fully well that the choice of infant feeding option can influence transmission of these babies. Then we also have HIV for HIV exposed children. We ensure that we give them antiretroviral therapy. We give the woman antiretroviral therapy in labor. That one is meant to protect the baby. Then those babies, once they are born, we give them, and we also continue about for 6 to 12 weeks till they have stopped breastfeeding. After they have stopped breastfeeding, then you ensure that we start them on cotrimoxazole, which is septrin. Septrin is cotrimoxazole for women who prophylaxis for these babies when they have 6 weeks of life. Next slide, please. So, HIV diagnosis testing of the child that is born to an HIV positive mother must be done at 6 weeks, then at 8 weeks of age, and 6 to 12 weeks after breastfeeding has ended. If the PCR cannot be done, the ordinary strip can be used in them. We can use ordinary strip in women or in children who are more than 18 months. For women who do not breastfeed their child, we just need to do that at birth, and at 6 weeks, then we don't need to continue to screen those children. Nutritional counseling and support for sexual and reproductive services must be offered these women. And what do we include? What do we mean? Offering them family planning after they have delivered. Cervical cancer screening, because the incidence of cervical cancer is in women who have HIV, and psychosocial support, because it is a lifelong disease. So we need to give them mental support. We need to help them with their psyche, that they will not have low self-esteem. And also we need to do partner counseling and pre and post-exposure prophylaxis for serodiscontant couples, where if by the time there's full disclosure from the other partner. Next slide, please. Next slide. Okay, so antiviral treatments. What are the things we've said that all women must be on it? So what are the things you need to do? You want to be sure about the history, confirm the status, physical examination, to be sure that there is no other systemic involvement in this patient, especially the chest. What are the tests we need to look for? The routine pregnancy test, hepatitis B, syphilis, because it's common, it's common in this way to have an abnormal result. Don't say that I've done syphilis screening, I've not sent anybody positive. You just be surprised. Tuberculosis screening and every other screening that we normally do for women who have a child, who are pregnant, who come to antenatal clinic. So next slide, please. Pregnancy in an HIV positive woman is an absolute indication for antiretroviral therapy, irrespective of the gestational age or the stage of the disease. And it should be initiated urgently in all breastfeeding and pregnant women. If they identify, if they are delivered before you identify them, you need to start it. Same day that you get the results, start the same day. Except in women who have acute immunity diseases, that they can now react to their retroviral drugs. We need to start the same day because it reduces the viral load in them and reduces the transmission. Next slide, please. So for infants of mothers that are exposed to HIV, we have the one that we call the low risk, we have the one that we call the high risk. Infants that are low risk, we will talk about the criteria for the high risk before. You just have to give them a river pain. Nevirapine only once for 6 weeks. But women who continue breastfeeding need the infant to continue this nevirapine until 8 to 12 weeks after stopping breastfeeding. Whereas the infants who have mothers who are at high risk of having this HIV needs to be on nevirapine and zidovudine, two antiretrovirals. And this zidovudine is given twice daily for the first 12 weeks of life instead of 6 weeks. And if they are breastfed, it must continue to 8 to 12 weeks after they are finished breastfeeding. And this antiretroviral prophylaxis should be initiated within the first 72 hours of birth, because in the earlier you start it, the better the outcome and the better the prevention for these babies. So what are the criteria for saying that this baby is high risk for HIV? They are born to women who have established infection as at the time of diagnosis, and women who have not been on artificial reproductive, women who have not been on antiretroviral treatment about less than 4 weeks before delivery. Women who have viral load of more than 1,000 before they were delivered. Women, infants of women who have HIV, who acquired HIV infection during pregnancy, or who were first recognized in the postpartum period, or without a negative test in pregnancy, but now having a positive test in the puerperium. Those children at risk, they are the ones that will have dual antiretroviral therapy. So people at labor, delivery, and the puerperium, we should remember that these children must not be stigmatized. So they must not be isolated. They must be kept in the same room with other women. You cannot get HIV from contacting with people or sitting close to them. We should offer them standard obstetric care, and we should not label them and their family members. When they come to us in labor, we should make sure that we clean their vagina regularly with warm fluoxetine solution, 0.25%. Why? So that they will not have reactions. And we should avoid vaginal examination. We should avoid episiotomy. We should avoid making the cord. We should avoid to say we are rubbing the baby's mouth and nose, but immediately the baby is coming out before we even crack. And the babies are born, we should put them under the woman and so that they don't develop rashes on their body, which can increase the transmission. And we should try and avoid instrumental delivery. If we must use instrumental delivery at all, it's vacuum delivery that is recommended. And immediately the baby is born, your umbilical cord is clamped, and your umbilical cord around the gauze before you cut, so that the blood does not spot. Then, next slide, please. We should have babies born with gloves, irrespective of the HIV status. And we must function at all. We must use the bulb suction, we must use the mechanical suction. We should not use that rigid suction that can create wound or injury in the mouth of the baby. And the baby can be placed on the mother's chest for skin-to-skin contact. HIV is not contacted through body contact, don't forget. And in summary, given the successes that have been recorded in mother-to-child transmission of HIV, the global community is moving towards prevention to elimination. We don't even want it at all. We should remember that in the absence of any preventive measures, the rate of occurrence of mother-to-child transmission is 25 to 40%. Imagine these children, less born, taking drugs throughout their life. Automatically, it reduces lifespan. Who wants to live like that? To stop the vertical transmission of HIV, there are different packages that we have discussed today with the aim of reducing this transmission. And that's what we talk about, the 4 pillars. Please do not forget the 4 pillars. Thank you, everybody, for listening.
Thank you so much, Dr. Ayeni. I expect to be seeing our hands clapping in the chat box. That has been a very rounded and very insightful presentation. She covered, from just talking about the routes of transmission to the pillars of PMTCT, the 4 pillars, 4 key pillars, which she also reiterated at the end of the presentation, and also just underscoring the importance of appropriate counseling and messaging to, drive informed choices and reduce risk of transmission. We appreciate you. Thank you so much, Dr. Ayeni.